and allow for flexibility. So they're not sitting up like upright sticks. You notice that on the trabeculae in the long bones and the real bone, you notice that there was a bit of a woven and kind of an arching effect of the spicules. And that then is due to the orientation of where the stress is the most. So in this area here, okay, you're going to be looking at this next week, but over the weekend you're going to start putting together some of the upper appendicular skeleton. This is lower appendicular skeleton. This is the head of the femur, and it fits into the acetabulum, into that little cup-like structure in the os coxa. And you'll have some stress in there, but that head is very tightly packed in there. And there's even a ligament that holds it in position, so it's well protected. Okay? But as you walk and the weight of your body pushes onto the head, that stress lines begin to then appear, okay? And you're going to have, at this point here, the greatest amount of compression. It's the same thing with the head of the humerus. You're going to find out that on the head of the humerus, you always have below, you have a neck. So if this is my head, the rounded area, then the section right here has got to be the neck, just below, just like your neck, okay? And then we get down to some projections that muscle's attached to. Same thing with my humerus. I've got a head, and then I have what we call an anatomical neck because it's just below, and you see like a constriction. Then I get down to the condyles, and then just below that, in the same place, I'm going to have my surgical neck. The surgical neck is where I have the greatest amount of stress. So this is the most common site for breaks, okay, at that location, because we've got stress lines that give some flexibility, they can bend, but at this point here, we don't have any more bending, or we have minimal bending. We have compact bone, we have some spongy bone, but now it's the strength. So this part here can still bounce, this part here does not. So at that intersection, that's where I'm going to have the greatest amount of stress, and that's where I'm going to have my breaks. Okay? So, according to Wolff's Law, the amount of, it says the bone grows or remodels in response to the demands placed on it. So, if you walk, okay, as a normal everyday habit, the amount of your weight pushing against that femur is then going to put stress on the neck. This is the neck, but this part here at the junction, and then that's where you're going to start building bone, because that's where most of it's going to break. So you increase the amount of bone where you have the greatest amount of stress. That's what Wolff's Law is. So as you're lifting weights, depending upon where the stress is on the bone, you're going to start increasing the width of the bone that's going to receive the most amount of stress. That is what Wolff's Law implies. So we're going to create some spongy bone. We're going to start adding to the compact bone. Okay, so we're going to have then the compact bone thickening. We want to reduce the probability of a break. So we're going to increase the amount of compact bone so that we can have then a reduction in the probability of a break. Okay? So curved bones are thickest where they're most likely going to be buckling. So right here, this is where I'm going to have the thickest compact to spongy bone ratio, because that's where most of my stress is located. Okay. So what do I need to know about this? Oh, it's mechanical stress. That's the greatest promoter of bone remodeling in the adult. We still have growth hormone, but we don't have it nearly as abundant because we're not growing anymore, to be honest. The bone elongation and all that stuff happens early on. So we now know that this mechanical stress is the greatest factor in increasing bone remodeling in the adult. But in addition, we know a little bit now about Wolff's Law. So those of you who are going into kinesiology, sports medicine, you're going to be looking at then the different kinds of stressors, which then relates to then what kinds of fractures you're going to have. Okay? So we have then Wolff's Law. So that's associated with the location in which you have the greatest amount of stress. Okay? And you're going to find that the area that the muscle is going to attach to, let's say that you're doing some bicep curls, okay? I need to increase the amount of the process that the biceps is going to attach onto. So my radial tuberosity, I'm going to start increasing the size of that to accommodate the increasing mass of my muscle. It just is, if you just stop and think about it, you go, oh yeah, that makes sense. It's not a factoid that you're memorizing, it just makes sense. The greater the amount of pressure and pull, the greater the probability of bone remodeling and enhancing the size of the bone at that attachment. Okay? All right, so why are bones remodeled in adults? Blood calcium levels, number one, okay? And then also, we need to be able to, depending upon our activity level, accommodate bone mass relative to muscle mass. And then if I were to break a bone, I need to have some mechanism in which I can then remodel, at least repair and then remodel. Okay, so why do exercisers have denser and stronger bones? I think that this makes sense. Okay. B, bones develop over longer time periods and exercises. Exercises need more calcium. That's pretty much all three, basically. Okay, it's all three, but you just need, not calcium for the muscles, it's calcium for the bones. So, see, I didn't read it right either. I read it too quickly. Right? Just like you would too. We all do it. Okay. So, we do need to then add more bone tissue to compensate. Okay, so now let's look at some bone fractures. Now your book goes into a little bit more than what I have on here. You just need to be able to identify these. Okay, this is what I'm going to put on the test. Okay, these different types of bone fractures and who is the most likely person who's going to be affected by that type of fracture. So bone fractures are classified by whether or not the bones are displaced or not displaced. Okay, so wherever the bone breaks, do they stay together or are they separated? Okay, displaced or non-displaced. Okay. Secondly, is it all the way through the bone or partially through the bone? Is it a hairline fracture? Okay, so is a bone separated? And you can see here on the photograph, and I'll take out, for those of you who are really interested, there are a number of x-rays that we have. We've got an x-ray light in the room. You can go ahead and put the x-ray film up and go ahead and check to see some of the different kinds of fractures that we've obtained through those photos. Okay, the x-ray film. So go ahead and take a look just so you can see, oh yeah, that's pretty, some of them are really very interesting breaks, I'm telling you. And then, the orientation of the bone to the long axis. Is it along the axis or is it across the axis? Okay. Each one of those factors is going to determine the rate and level of repair. That's why they need to know where it's at. Do we put in pins? Can it just be localized? Do we need to cast it? You know, those are the different things that a physician is going to make a determination on as to how we're going to keep that bone and in position so that we get the maximal repair to that. And then if it pierces the skin, if it's so severe that it pierces the skin, then that's a compound fracture. Okay, so a compound fracture will penetrate through the skin. Okay, and so you've got different ways in which you can now classify the kinds of breaks. Okay, these are the different classifications. Okay, so let's look at some of the more common fractures. Okay, diminutive. All right, so you can see what happens in this kind of a fracture. You'll notice that here's the x-ray. This is the diagram which illustrates it. You've got multiple pieces. Okay, that could be due to compression, could be due to a number of different reasons. You could fall into a hole, basically. If you're an elderly patient, you can actually just break a large portion of the area close to your ankle, right? So I'm going to have then these multiple fracture lines. This is more common in aged individuals where the bone is a bit more brittle. So it's easier to break. Multiple fractures. Compression fracture. You can compress a bone, you can get some hairline fractures through that bone. And this is where the bone is crushed. And it's more common in areas where we have porous bones. So in the body, we don't have a cut through a vertebrae, but in that body, you've got a lot of spongy bone. It's an irregular bone, we already learned that, but you have an outer shell of compact bone and a lot of spongy. That also allows for some compression, and then you have their intervertebral discs, which is gonna add to the ability for the compression. So you're gonna have some flexibility there. But again, if it's very porous, you can, if you're in a car accident, it could be a compression fracture. Okay. Another one is a spiral fracture. And that's when your feet are planted, you've got your cleats in your shoes, and you just twist really hard. Somebody hits you on the side at the same time. And we have then a fracture, which is a spiral fracture. It's more common in sports because that's often a result of turning and then having the bone kind of seated, but then you're putting a rotational twist on it. And so that would then be, you can see how that would appear. Okay, so that would be a spiral fracture. Then we have an epiphyseal fracture. And that was when we still have an epiphyseal plate. So it's going to be before puberty. And in that case, we're going to see then at that epiphyseal plate, the two ends of the bone are going to come apart. Okay, because it's cartilaginous. So they can slip across each other, and you then have this epiphyseal fracture. Another one is a depressed fracture. It's when you have compression or you have an inward break due to a blunt force trauma to the skull. So it's typically associated with the skull. Okay. A green stick. Now, a green stick is easy to kind of remember because you usually, when you look at a young growing tree and you have a young shooting branch coming off of it, it's really hard to take that branch and just break it off because it's still growing. So it might break on one side, but not all the way through. Okay, so that is a green stick where you have then an incomplete fracture. Okay? And it's typically more found more in children where you have more organic to inorganic ratio. The bones are still growing, so you're going to have a lot of collagen. So it's not going to be a clean break. Okay, so that would be a green stick break. So for each of those, you need to be able to tell what's my population that I'm going to most likely see it in. I would not be looking for a green stick fracture in an elderly patient. You know what I'm saying? It just doesn't jive. So you want to, if you're, and you've got a sports injury, oh, you think, oh, maybe that could be a spiral fracture, right? So you have some idea of the activity that may contribute to a kind of a fracture. Okay, so let's say that you do break a bone. I don't know, I have to knock on wood, I've been fortunate, I've not broken a bone, but I've never, except for playing tennis, I mean, how do you break a bone in tennis? I don't know how you, like you fall on your head. I don't know, but bottom line is that most of you who have broken a bone can tell that you have, right? Not only do you feel the pain, you go, oh my gosh, that hurts so bad, and maybe other words besides, but you're saying, that hurts so bad, and then you can't barely even move it because it's still very, very painful, and you go, I think I just need to relax that bone for a little bit, and then you notice it getting black and blue. So one of the first things that you're going to find in a broken bone is obviously the initial injury, and you're going, oh, that really hurts. And then you're going to start seeing bruising, and that's because you've broken blood vessels now. Bone is highly vascularized, so you're going to start having a hematoma formation. Depending upon the severity of the break, the location of the break, that hematoma can emerge relatively quickly, or maybe overnight. You just kind of go, oh man, I got to just relax this. I don't even want to see it. You know what I'm saying? So that could be then the hematoma formation, and that's stage 1. So when you have the injury compounded with that hematoma, that's when you go into urgent care. You go, you know, because sometimes you kind of wonder, should I go into urgent care? Is it worth going into urgent care for this here? I'm just going to wait a little bit, and then when you start then you go, I think I need to go into urgent care, okay? So, it can be immediate, or it can be 1 or 2 days later, okay? So it might be a slow bleed. So it, and that, again, it depends upon the severity of the fracture. You have torn blood vessels, so you're getting hemorrhaging, which then is going to be clot formation there. That hematoma is then going to be located at the fracture site. I need it there, because what I need to do is I need to plug up the blood vessels. So I need to have some clot formation. That's the normal response, okay? And at the same time, you're sending in as many white blood cells to try to protect the area. Whenever you have a broken vessel, you want to make certain nothing gets into the blood, because it's one of the 2 sterile places in your body. So you don't want anything getting in there from whatever damage that you might have. So the blood is rushing down there, and then you're going to have, obviously, mast cells in the connective tissue surrounding it. They're going to release some histamine, right? Heparin. And so they're initiating an inflammatory response. Okay, so then what happens at that point? Vasodilation. Blood vessels start to open up so that the white blood cells can go out into the area and start cleaning it up. So when that happens, I lose plasma from the blood, and it goes then into the tissue, and it becomes swollen, edema. Then when the fluid goes in there and it's pushing against the pain receptors, pain. Because I have vasodilation and I got lots more blood vessels or blood cells getting down there, it's going to be red. So an inflammatory response, you're going to have swollen, redness, you're going to have heat too. And the reason you got heat is all those cells are now aggregating at the location. They're all metabolically active, trying to get rid of whatever crud is around, dead cells, bacteria, whatever might be there. And so they're very actively metabolizing, so it's going to get hot. That tells you you have an inflammatory response. Okay? So this is all kind of going on simultaneously. So an inflammatory response is, and we've talked about that with mast cell. Okay? Then, once I've cleaned everything up, within a few days to the next week, you're going to get, of course, you're going to get x-ray. They're going to make a determination whether you need to have a cast on. You want to immobilize the bones so that they're not moving. You want to optimize the ability for the bones to mend. So we start to form a fibrocartilaginous callus. The fibrocartilage is the initial part that we need to get in there in order to become bone. So it's a fibrocartilaginous callus. A callus just means a growth, okay? And that can be anywhere from a few days to longer. We're going to start to, of course, okay, this is my break. I'm going to have to put in now this callus to kind of bridge the gap, okay? There may be a gap. As much as I'm going to try to align it and get it back together, it's never going to be complete at the initial break. So we're going to start forming this fibrocartilaginous callus. We're going to have blood, so it's a soft callus, and we're going to have blood vessels start to come in. Okay? Got to have the blood vessels because that's where the calcium is. Got to bring that calcium in there. I got to also bring in appropriate hormones and various kinds of chemicals to convert that fibrocartilaginous callus into a bony callus. Okay? So I need to bring in blood vessels. I still need to bring in those white blood cells because I still got to clean up. I can't do it all magically, maybe in a day. It might take a little bit longer because something might sneak in. So as a result, we need to be able to clean up anything that should not be there as we begin to create new bone. That's what we've got to do. Clean it up before we deposit the bone. Okay, so which cells are going to come in there? Well, this should make sense to you. If I'm creating new bone, osteoblasts. If I'm creating fibrocartilage, fibroblasts. Okay? So I'm going to be bringing in through the blood these various cells, and they're going to start initiating all of that fibrocartilaginous callus production. Okay? So what are the fibroblasts going to do? Oh, secretes collagen. Okay. So these collagen fibers are going to help to connect the bone. Some of the collagen fibers are going to be contributing to the fibrocartilage itself. Okay? So this all kind of makes sense now that you're putting an application to what the function of those cells are in the location and in the process. You're going, okay, this begins to make sense. So initially, the osteoblasts begin forming spongy bone because it's easier. It's just spicules, they're just needles. So it's not this compact bone, all highly organized. Let's just get some bone in there and start bringing it together, getting some bony tissue in and closing that gap. Okay, so then we're going to have bone production, and we form then a bony callus. So it could be anywhere from a few weeks to a few months. And again, why the variability? Well, nutritional status of the patient, age of the patient, okay, those are contributing factors, and then the severity of the break. I think it's very logical. The older you get, the slower it goes, okay? If you're not nutritionally sound, don't have a healthy diet, well, we're going to have to start getting in some of those various vitamins and enhance the diet to be able to then form new bone. Okay, so the bony callus is going to form, and we're going to start increasing this from the spicules to trabeculae. So we're going to get woven bone, and it's going to then be spongy bone. Okay. So it's becoming more of a network and more complex. Turns into the fibrocartilage turns into my bony callus. Okay. So I'm converting cartilage to bone. Now, once I have that bone put in place, it's never going to be nice and clean initially. I have to clean it back up, and I have to kind of whittle it to make it look right. So that initially it starts out as, here's bone, and then there's the callus. It kind of sticks out. So what I want to do is I want to narrow it so that it's complete, and I whittle it down so that it looks like a uniform bone. So we're going to have then bone remodeling. And that could be several months to even a year or longer. Again, depending upon all those factors that I've already described. Okay. So the bone remodeling is going to take the excess bone and make it look uniform. Okay. And we're going to start depositing more compact bone. Okay, so we're cleaning it up, depositing it, where we have then the compact bone. Again, depending upon where that break is. If it's at the epiphyseal plate, that's a little bit different, right? So we have then this bone remodeling. So I've got then the 4 steps. So is that what one of my questions was? What are the 4 steps? Okay, in the bone repair? Okay, first one, hematoma formation. Then we're going to have the fibrocartilaginous callus formation, the bony callus formation, and then bone remodeling. And for each one of those, you want to not just list them, but describe them. I only need 1 or 2 sentences, but tell me that you know something about it, that you haven't just regurgitated the steps. What does that even mean? Okay, so that will be another question that you would be able to answer. Okay, so we've talked about how bone, a little bit about the overall physiology. We just barely touch on it, but give you some, some insight into bone as being a living tissue instead of that inert, non-living thing that we see in the lab. It really is comprised of cells that function together to then create then the structure that you want to maintain for the remainder of your life. However, we're going to now look at some of those imbalances, homeostatic imbalances, because this happens as well. Some of it is part of aging, some of it is dietary insufficiencies. So we're going to look at just a couple, not a lot. Okay, I'm going to talk more about the different forms of arthritis when I get to the joints. So I'm just looking at bone formation right now, not joint structures. So bone. So the first one that we have listed here is osteomalacia. In an osteomalacia, it's inadequately mineralized. So for some reason, I'm not depositing my calcium and forming hydroxyapatite. Instead, I have the ratio of collagen exceeding my compact bone. So as a result, I'm going to have soft bones in the adult. Now most of this, well, a couple of symptoms, well, it should make sense. You know, bones are highly vascularized, highly innervated. So when you have that happening, it's going to hurt. I mean, have you ever had shin splints? No. No? It hurts. Okay. Have you ever like stubbed your toe or got kicked in the shin? It hurts. Okay. So it's highly vascularized and highly innervated. So when you have bone involvement, it hurts. Okay. Carcinoma of the bone, osteocarcinoma. It's osteosarcoma. A sarcoma is associated with connective tissue. And then a carcinoma is associated with epithelial tissue or glandular tissue. That's the difference between the two. So osteosarcoma. So the main symptom is going to be pain, okay? Because now they're too flexible. They're not mineralized enough. So oftentimes it's a diet insufficient in calcium. Now most often when we think about calcium, we think about, oh, milk, cheese. Okay, there are other sources of calcium, broccoli. Okay, so there are other vegetables that are rich in calcium. But what happens is that if you do not have vitamin D, then the calcium does not deposit, or it's not effectively deposited. So vitamin D, even though it's a vitamin, most endocrinologists feel that it's more of a hormone, that it assists then in the deposition of calcium into bone. So if you have the vitamin D deficiency, and we know that that's the precursors for that are in the skin, activated by UV light, so going out in the sunlight, we know most of us don't do that. So what happens then, and we don't take it in dietarily, they find that about 90 to 95% of the adults in the United States are deficient in vitamin D. So you take the vitamin D supplement to help in that. You don't self-medicate, you know, you want to make certain that, you know, what you are in terms of your baselines. But if you have a vitamin D deficiency or insufficient calcium, this is what's going to happen. The bones begin to bow out. They're not strong and upright. They bow out. They're softened. Okay? And so it's difficult to move around. It's difficult to walk. The strength of the bone is diminished. Now that's in the adult. So osteomalacia is a lack of mineralization or insufficient mineralization in the adult. In the child, it's called rickets. So when you have a child that's a toddler and they're just starting to walk and their bones are too soft, then their legs begin to bow out. Okay? So you have then, again, insufficient or inadequately mineralized bones. And this could be in various parts of the body. We often see it in the legs, so that's how you can tell there's something going on, because when you go into the pediatrician and they want to see how things are growing, circumference of the head, and they want to see if they're able to stand, you know, look at some reflexes. And if they see that the bones are a bit too bowed, especially if they're doing any little bit of walking, then they want to just check that, because that might be just this rickets. Same cause, you're going to have insufficient calcium, could be then vitamin D deficiency, but you can have it throughout the body, because it's the easiest way to find it is that it's in the legs, but you can see the deformities throughout the entire body. Mm-hmm.
Is it reversible?
Mm-hmm. Just have to supplement. Mm-hmm. It does kind of to a secondary degree. Okay, if you're constantly holding them and you're not having Okay, there is a possibility of doing something like that with them wrapping, but if there's really, children want to be a little bit more independent, they want to learn to walk, and then that's when you actually start seeing that. Okay, but you all have a little bit of that as a result of clothing. It's the same thing like if you leave your baby on the back of their head and their head then flattens out, right? Yeah, that happens too. So what you want to do is you got to kind of rotate them a bit, you know what I'm saying? Like a barbecue. I don't know. You got to rotate them around. Don't let them just be on their head. Okay, so then again, same cause. Insufficient calcium in the diet or vitamin D deficiency. And you can enhance that by taking supplements. So oftentimes you, as a young child, as an infant, you take those different kinds of infant vitamins, etc., right, to help. And then you also have mineral supplements as well. Okay? And of course you don't have to take it just as medication. It's just proper diet. So if you feed the babies, the infants, some diverse foods and let them sample a number of different good foods, then their palate begins to be trained to eat the good foods, and then you can enhance their dietary intake and not completely eliminate, but reduce the probability of some of these that can happen. So, and for mothers that are deficient in vitamins themselves, okay, the infant is going to be the optimal parasite, right? I don't want to be, it's just, that's what it is. They're going to take all of your vitamins, but if you're not having enough, then obviously they may not be getting enough. Right? So you got to have a good dietary intake in order to nurse your babies. Okay, another abnormality is osteoporosis. In osteoporosis, you can see reabsorption outpaces deposition. Okay, so that means that the bones become more brittle, less compact bone. And it's more common in women than it is in men, although men are not excluded from this, right? It is associated with hormonal levels, okay? But that's not the only. So you'll see that if you were to test 30% of women over the age of 16-70 will have some form of osteoporosis. 70% of them will have some form of osteoporosis by the time they're 80. But men are a little bit less because it's estrogen related. So you can see the difference. This is your normal bone matrix, and this is taken then from the neck of the femur, and most of my breaks are going to be either here or here. Lots of spongy bone, okay, where my stress lines are located. So this is what it's going to look like in the normal. This is what it's going to look like in osteoporosis. So you're going to have less deposition, okay? So, and it becomes more porous, more brittle as a result. So any kind of a fall can result in a broken hip, right? Because it's already gone through that process of bone minimization. You're getting some abnormalities in that. So when it looks like this, bones are more fragile, greater abundance of spongy bone, compact bone is significantly reduced, and so you can have then this break. Now, oftentimes, it's not just here in the hip, but the vertebral column, because the body of the vertebrae have spongy bone. So if you're recycling or if you're doing any kind of bone remodeling in the vertebrae, and you're now going to make it spongier than compact, then you can have then changes in the body of the vertebrae, which then can result in different types of abnormalities in, kyphosis, when you're hunched over, okay, because of poor bone deposition. Did you have a question? Yeah. Exactly. So it's compression of the vertebrae, it's compression of the body of the vertebrae, intervertebral disc. Okay. Okay, so what are some of the treatments? Very easily, everything, if you just have a good diet. That's the basis of everything. Good dietary intake, the colors of the rainbow in your vegetables, right? Having the sufficient amounts of calcium. And again, it doesn't have to be milk. It can be broccoli, it can be supplements, it can be different kinds of foods. So all you have to do is making certain that you have calcium, but also making certain that you have the vitamin D. Now, it's very unusual to be able to find the two separate. If you're taking that as a supplement, it's usually calcium and D3, so that you're getting both of those coming in at the same time, so that the calcium can then be deposited appropriately. So that's one way, okay, that you can check. And how do we tell that? Well, you do blood tests, right? You do your initial annual checkup, and you do your blood screening, and it will tell you your calcium levels, if it's low, and your vitamin D levels. And if it's too low, then they're going to ask you to step it up, either by taking supplements and also adjusting your diet to then incorporate more of the healthy foods. The other thing that you can do to help prevent osteoporosis, or you're not going to necessarily prevent it, you're going to slow down its progress, let's just say it that way, okay, is to do some weight-bearing exercise. That just simply means walking every day. 30, 45 minutes every day. That's all you have to do. Just maintain that exercise, which whenever you put stress on the bone, like I said, if you don't use it, you lose it, right? So if you don't put stress on the bone, and it's not going to remodel right. So walk as much as you can. You drive, you park further away so that you can walk. So you get some more. It doesn't have to be that you're walking around a track. You can get those different kinds of exercises in a multitude of ways. Another one is to do hormone replacement therapy. But a lot of people don't like to do hormone replacement therapy because there's a correlation between HRT and breast cancer. So some people just say, yep, not going to do that. And oftentimes you'll find that different doctors have a different way of treating, okay? And some people really push HRT, and others say, well, you don't have to do that. And just know that you are producing estrogen. As you get older and the estrogen levels begin to diminish, you have then the corticosteroids, the different kinds of sex hormone precursors in the adrenals. I mean, when you think about it, if the sex drive is based on testosterone and we don't have testosterone in abundance, then what creates the sex drive in the female? It's got to be something in there. It's the adrenals. So you're going to get some levels of sex hormones that are produced in the adrenals to supplement. So you don't have to do this HRT. More and more women are choosing not to do that. Okay? Now, if it gets really severe, and they're going to, they do bone density. So, okay, just TMI, but I'm going to go in for bone density because, when you get older, you go, okay, I got to just do whatever I can to stop the process of aging, right? So I need to know what's my baseline. So I'll let you know how that test goes. Okay? So then what I got to do then is, got to do what I'm just telling you to do. Okay. All right. So if it's exceeding, and then you can tell that the calcium, the bone density is just way off, then you're going to take some statins. You're going to be much more aggressive, okay? You're going to take some medicines that are going to help then increase the mineral density so that it becomes stronger. Because again, you just want to avert as much as possible any kind of outcomes of aging. Another example of a abnormal ratio of deposition of bone is that of Paget's disease. In Paget's, look at this bone. Okay, it's haphazard. It's just irregularly arranged. There's no concise area of compact bone with spongy bone. It just looks like the whole thing is full of spicules, okay? So we're going to have excessive bone deposition and reabsorption. It's not going to look nice and concrete as you would see in a normal x-ray of any normal bone, okay? And so you're going to have a lot more spongy to compact bone. So what does that mean in terms there's no strength in the bone, okay? And the Paget's disease is going to, of course, we expect it to have weakening of bone. There's no compact bone, or minimal, okay? We're gonna have, because bone is now highly innervated, we're gonna have pain. We're gonna start having changes in the bone structure itself as a result of this Paget's disease, okay? And you can see here, the osteoclast activity begins to diminish, but the osteoblast continues its metabolic activity. So I'm creating bone, but I'm not remodeling bone. Remember when you have remodeling, I have to have osteoclasts, right, to break down bone? And then I have to have the osteoblasts activated so they can deposit bone. And then I gotta have my osteocytes. Okay. Well, I'm not getting the proper activation of cells. The osteoblasts are not working. So they're making bone, but there's no way to remodel it, to make it look like anything that is organized. So we're gonna have this unusual kind of deposition. And it's idiopathic. We really don't know yet what causes it. Could be, in my estimation, everything under the sun is autoimmune reactions, autoimmunity. Okay, that's what I think everything is. But here, it could be stimulated, like when your immune system goes crazy due to a virus. So it could be a viral origin that interferes with the immune processing, and then you start recognizing your own proteins as being foreign, and you start attacking. So that's what happens in lupus, right? You're attacking your own DNA. So it then progresses into a multitude of different symptoms, depending upon it's more prevalent in women than it is in men. But what will happen is that you'll have then different kinds of symptomology, but you'll have a classic grouping of that lupus. So it could be possibly viral, and 3% of the Americans over 40 may have this and not be really aware of it. You have pain, and sometimes you kind of go, okay, beginning of arthritis, and until it becomes more painful, people don't go in. You know, I don't go in. Do you go in? I don't go in unless I have to go in. I don't want to go in. So I just wait until I can't take it anymore, and then let's do a blood series just to find out what's going on. And what we're going to do then is we're going to treat with different types of drugs, including statins, and then we're also going to give exogenous calcitonin. I need to have more bone. I have to have bone deposition. Actually, no, not bone deposition. Calcitonin is going to take it out. Okay. So, which of the following might help delay or even prevent the effects of osteoporosis? Plenty of calcium in the diet, getting regular exercise, resting bones as often as possible. I like D. I tell that to my grandkids. Okay. Yeah, that too, but really and truly, the first two. The osteoporosis relies more on exercise, not a sedentary lifestyle. So you want to be able to walk, do something to kind of keep the metabolism going, and then activate your cells. Okay, so we'll go ahead. This is the end of this section. I'm not going to start on the joints until Tuesday. So now you have some time, and of course that means that everything that we've had last Thursday, Tuesday, and tonight is part of the lecture quiz on Tuesday. Okay. It's all the physiology. So that lecture, again, you'll have 20 questions. They'll be worth a half a point each, so it'd be worth 10 points.